So this is us. Trends in methamphetamine use disorder, and related overdose deaths among adults in the United States. I literally just read that. We have two speakers today, Dr. Beth Hahn and Dr. Emily Einstein. Emily, like Kurt's going to probably...
No, I won't.
Fangirl you all day. But from NIDA to give us this awesome presentation. Quick announcements ahead of time.
Remember,
let you say the free CME.
Yeah, it's free CME. So you get free CME. All you got to do is answer those emails and fill out a little thing. So if you want
the
that
link at the end of the talk, there will be a thing in the chat.
Yep. And feel free to turn on your video. I do think these speakers would love to see faces.
I don't care if they're eating.
Yeah, we don't care if you're eating. Doesn't matter. Feel free to turn on so they have people to look at.
Y'all know it was recorded. You got the big alert, but if there's more than one person in your room, please chat that in as well. In terms of how we do Q&A, unless you two, Beth and Emily, want something different, if people chat in their questions, we can kind of help facilitate that at the end. If you want us to just interrupt you, Kurt's really good at that.
Yeah. Remember, we got some upcoming echoes that are going to be great. Especially on Wednesday. The Tuesday Echo is the final session. It's a wrap up this week. But on Wednesday, we have suicide prevention coming up, addiction legislation update by Charlie. And then
my favorite my favorite author in the world, of course, Sam Quinones, who wrote Dreamland, and the follow-up, The Least of Us.
November 2nd.
Everything you want to know about the epidemic in a firsthand, on the ground version. Anyway, so invite your friends. If you haven't read the books and you want to know anything, I recommend them.
Again, if you need some technical assistance, either reach out to Aaron. Our phone numbers are there. Always happy to answer some questions if you have questions about patient issues. And
then if you call Kurt and he doesn't know, which is common, you'll hear from me.
Yeah, I just refer it on. All right. And again, we do have that SOAR site. And remember that the core site, I think SOAR. Sorry. And remember, we will have the manual up very shortly.
It's getting submitted to the state, I promise.
In the next 48 hours.
Friday. And we had somebody ask us to add something to it just today. Danielle, thank you if you're on. So I have one more paper to write, but the podcast.
Yes. And the podcast this week was on, I can't remember.
Co-occurring mental health things. It was the end of the tips and tricks and random questions we get
for buprenorphine.
Yes. If anybody has any topics you'd like us to do a podcast on, there's how you can let us know. Otherwise, you know our other emails and phone numbers by this point.
All right.
So with that, yes, it's National Cream-Filled Donut Day, but even more pertinent to the real world is the speakers today and the methamphetamine trends. So I don't know which one of y'all is going to start talking, but I will stop.
All yours.
That'll be me. Hello. Thank you so much for having us this afternoon. I'm going to start out by giving some background about the study, and then I'll hand it over to Dr. Hahn, who will talk about the specifics of the analyses. So if we could go to the next slide. So the background is that methamphetamine is a powerful and extremely addictive psychostimulant. It is legally used sometimes. It's FDA approved for limited treatment of ADHD and narcolepsy, but the majority of misused methamphetamine is illicitly manufactured, and it's very easy to illicitly manufacture in small clandestine labs. Something that was unfortunate about the pandemic period is that the cartels that traffic methamphetamine really bounced back quite rapidly, so the supply has been quite steady. Methamphetamine is, even compared to other highly addictive substances such as opioids, it's uniquely toxic to the body. So it is associated with the development of addiction. It's also associated with other psychiatric comorbidities, increased viral transmission, and then really large-scale damage to other body systems such as the brain, the lungs, and the kidneys. So methamphetamine, we included this review article in the lower right-hand corner. It's a good snapshot of the current status of methamphetamine use in the United States, and Beth was an author on that as well. So if you're interested, we recommend perusal. So next slide, please. The US has experienced a real increase in morbidity and mortality associated with meth use, and this figure is just to demonstrate the change in overdose mortality associated with meth between 2015 and 2020. I think this also gives a good visual that previously methamphetamine use was largely concentrated to the Western United States, and now it's just ubiquitous nationwide. It's readily available and it's very pure and potent. Next slide, please. So this is breaking down that mortality by urbanicity. And you can see, so it goes from more urban to the left and then more rural to the right. And while mortality rates associated with methamphetamine are unacceptably high, they are the proportion of psychostimulant mortality attributable to methamphetamine is highest in rural areas. So in this graph, the blue bar is the cocaine category of overdose deaths, and the red bar is methamphetamine. Next slide, please. Another issue that is increasing mortality related to methamphetamine use is co-use of methamphetamine with illicitly manufactured fentanyl. So fentanyl is an incredibly potent opioid, and both of these substances have high risk of overdose mortality alone, but when they're taken in combination, that risk of mortality gets much higher. Next slide, please. So people give a variety of motivations for methamphetamine use. There is a widespread understanding among people who use drugs that fentanyl is very dangerous. So some people report using methamphetamine because they have the impression that it might be less dangerous than fentanyl or the contaminated illicit opioid supply. Sometimes people use it when their opioid of choice is not available, or they might use it to modulate the effects of opioid misuse. So people who use both opioids and stimulants report sometimes that they'll take the opioids when they want to relax and go to sleep, and they'll take the stimulants when they need to wake up and go to work, for example. And then people do also seek out the combination of opioids and methamphetamine for the specific subjective effects that they provide. It's described as sort of a different kind of high that sometimes people are seeking. Historically, just as methamphetamine use was once concentrated in the West and has expanded, previously methamphetamine use and use disorder were more highly associated with middle-aged white men, and especially men who have sex with men. For diagnostic purposes, the DSM is what is used to diagnose psychiatric conditions, and methamphetamine use disorder is characterized by compulsive methamphetamine seeking, continuing using methamphetamine despite the negative impact it might have on a person's life, and loss of control over methamphetamine use. Next slide, please. So it's still undetermined how trends in methamphetamine use, especially among vulnerable populations, as well as specific ways of using methamphetamine, might be driving this overdose in this increase in overdose mortality from methamphetamine that we've been seeing. So as you look at the results of the study, keep in mind these 4 different versions of methamphetamine use that we're able to assess with the NIST data. So there's methamphetamine use overall, methamphetamine use disorder, injection of methamphetamine, and frequent methamphetamine use, which is described as using it for greater than or equal to 100 days in the past year. So obviously, any methamphetamine use can be associated with risk of overdose mortality, but methamphetamine use in the absence of those other factors, use disorder, injection, and frequency, is a lower risk version of methamphetamine use than the others. So that's just something to kind of keep in mind when you look at the data. So we did these studies because understanding changes in the patterns of methamphetamine use as a function of age, sex and sexual orientation, and race and ethnicity can help us understand these increases in overdose mortality that we're seeing, and really importantly inform the prevention and treatment interventions that we can be beefing up in order to respond. It's also important for us to understand the factors in someone's life that are associated with methamphetamine use, frequent use, use disorder, and injection. Once again, to guide the strategies that can best address the causes of the increases in methamphetamine overdose deaths. So in the next slide, I will turn it over to Dr. Hunt to describe the study.
Thank you, Dr. Einstein. We examined 2015 through 2019 National Surveys on Drug Use and Health, we call NIST, which were conducted by SAMHSA, another agency that were part of NIH actually before 1992. You can see the picture on the right corner showing that NIST used multi-stage complex sampling design, providing nationally represented data on methamphetamine use, use disorder, frequency of use, and methamphetamine injection among the U.S. civilians and institutionalized population age 12 or older. So data collection was through the personal household interview using audio computer assist self-administered interviewing. And you can see the response rate for the screening response rate and interview response rate, both are very reasonable. To learn more about NIST and the collection method and related result, you can read our report. Actually, that's a report I wrote from beginning to the end before I came to NIDA. Next slide, please. We also examined the National Vital Statistics System, multiple cause of death data, which include every single death occurred in the US. We used the ICD-10 code, examined the number of drug overdose deaths involving methamphetamine with and without opioids or cocaine, and age-adjusted overdose death rate involving methamphetamine with and without fentanyl. Next slide. We conduct descriptive analysis on trend in these outcomes that I mentioned. And we also conduct bivariable and multivariable multinomial logic regression, which allow us to examine the three mutually exclusive outcomes simultaneously: methamphetamine use disorder, and injection. Among those aged 18 to 64, among people who use methamphetamine, we're talking about the users of this age, we conduct variable and multivariable logic regression to examine the correlates of frequent methamphetamine use. Next slide. This slide shows you the numbers of overdose deaths involving methamphetamine over time. You can see for methamphetamine overall, methamphetamine without opioids, without cocaine, and methamphetamine without opioids or cocaine. You can see all these numbers are significantly and dramatically increased from 2015 to 2019. Next slide. This slide shows you the age-adjusted overdose death rates involving methamphetamine by race ethnicity among those aged 25 to 54. You can see the rates increased significantly from 2011 to 2018, especially among the non-Hispanic AIN adults. And even for those non-Hispanic Black, see the green color? It increased 10 times over this time period. Next slide. As our nation is combating the drug overdose crisis, we are also facing the COVID-19 pandemic, the unprecedented crisis worldwide. Next slide. This slide shows you the age-adjusted drug overdose death rate involving both methamphetamine and fentanyl by age, sex, and ethnicity. You can see the navy blue bar represent March to August 2018. The purple bar represent March to August 2020, when the COVID started. And red bar represent March to August 2021. For almost all examined subgroups, you can see the rates continue to increase from 2018 throughout the COVID-19 pandemic. And especially you can see the highest rate were among the non-Hispanic AIN people for both men and women for both age groups. Next slide. And we find similar pattern for age-adjusted drug overdose death rate involving methamphetamine without fentanyl. And you can see similar pattern, again, the highest rate among Hispanic AIN adults. You can see for both men and women. And I want to highlight that methamphetamine overdose mortality actually is only the peak of the iceberg. Next slide will show you the base of the iceberg. Thank you. Next slide, please. Yes, this is the base. Why we talk about base is the number in thousand. I will tell you more why we say number in thousand people with methamphetamine use disorder, injection, and frequent use among this adult population age 18 to 64. For example, look at the right column. In 2019, almost 2 million. We think about you have to add 3 zeros. All this number actually is number in thousands. So it's almost 2 million people in 2019 actually used methamphetamine in the past 12 months. And over 1 million, we're talking about over half the people who use methamphetamine actually had methamphetamine use disorder. And then you look at that, and over half the people, over 1 million, you can see who use methamphetamine in the past 12 months, they used it 100 days or more. So most indicators you can see is highly significant. You can see that this number increased significantly, except for the methamphetamine injection. And for methamphetamine use disorder and the frequent use increase indicate that the severity and intensity of methamphetamine use pattern increased just within the 5-year period. You can see quickly. So, which actually consistent with the peak of the iceberg, showing the dramatic increase in methamphetamine overdose death. Next slide. Well, when we talk about the last slide, we talk about we didn't see increase in methamphetamine injection. And this slide show actually is our upcoming study showing that for methamphetamine injection, a number after methamphetamine treatment admission to U.S. substance treatment facilities, reporting injection as their usual route of methamphetamine use. Actually, you can see increased from 2010 to 2019. Next slide, please. This slide shows you the adjusted prevalence of past year methamphetamine use disorder, and methamphetamine injection based on the multivariable, nomial logic regression. As I mentioned, we were able to examine all these 3 outcomes simultaneously. For example, within each table shell, adjusted prevalence in red is significantly different from the highlighted reference group, which in yellow. For methamphetamine use, you can see adjusted prevalence was higher in 2019 than 2017. For methamphetamine use disorder, adjusted prevalence in 2019 was higher than 2015 and 2016. And then consistent to our trend earlier slide showing that we didn't see difference in methamphetamine injection. Again, this is population study for this table. And when we look at for age, and you can see across all these 3 outcomes, the adjusted prevalence of those age 24 or older were significantly higher than those age 18 to 23. They're showing the older age actually associated with these 3 outcomes. Next slide. Regarding sex and sexual orientation, you can see for methamphetamine, adjusted prevalence was significantly higher for gay men than heterosexual women. For methamphetamine use disorder, adjusted prevalence was higher for heterosexual men than heterosexual women. For injection, the adjusted prevalence was higher for gay men, bisexual women, heterosexual men than heterosexual women, but it was lower by lesbian women than heterosexual women. regarding risk ethnicity, you can see across all these three outcomes, non-Hispanic Black were significantly lower than the other racial ethnic group that are highlighted in red. Next slide, please. So this slide shows you the increase in adjusted prevalence of methamphetamine use disorder by age. You can see all these age groups that we examined increased during the two-time period. Even for those age 18 to 23, when we talk about those that group has the lowest risk, you can see that increased as well. Next slide. And Dr. Einstein mentioned historically, methamphetamine is a middle-aged white man, especially gay man issue. But now you see the increase in methamphetamine use disorder. We can see it increased for all the sex bisexual orientation groups that we examined. Just within the two-time period. Next slide. And again, you can see the increase in adjusted prevalence of methamphetamine use disorder for most racial ethnic group. Even for non-Hispanic Black, you see it just within the 5-year period from 2015 to 2019, you see the prevalence increased 10 times. And again, I want to mention these are adjusted prevalence. That means we controlled 23 variables, and you see it still increased dramatically. And for non-Hispanic AIN population, the prevalence has been persistently higher than other groups. Next slide. This study actually based our exam among people who use methamphetamine age 18 to 64. You can see the adjusted prevalence of frequent methamphetamine use was significantly higher in 2019 than 2015. Was significantly higher for those with methamphetamine use disorder or methamphetamine injection than those without. Again, these multi-variable analysis confirmed our earlier trend results. So they all consistent supporting why the overdose mortality rate increased dramatically over time. Next slide, please.
So I will jump in to discuss the study limitations and the take-home messages. And I was just slightly distracted by a question in the chat, which I might as well talk about now, because it's talking about how we use the terms gay and homosexual rather than men who have sex with men, when it's likely that behavior that is specifically lending risk. And so part of that is a study limitation. So we use the terms that are specifically assessed by the National Survey on Drug Use and Health. The National Survey on Drug Use and Health does not assess if you're a man who has sex with men. It assesses it by the terms that we used. So that's why we did it that way for this study. So the limitations for this study are the ones that are kind of inherent in these data sets as that one. So the NSDA is cross-sectional, so we're not able to determine causality from the data that we analyzed from the NSDA. It's also very possible that we're underestimating the prevalence of these behaviors because NSDA excludes especially high-risk populations. It's just the way the survey is designed, but unfortunately, the populations who aren't assessed are particularly at high risk for these behaviors. And those include people who are experiencing homelessness and not currently living in shelters, and institutionalized populations. So both of those have a high risk of these behaviors. The NSDA is also a self-report survey. So it's very possible that people might not accurately remember their drug use, and then they might not necessarily be willing to be honest about their drug use in the survey. As far as the mortality data are concerned, those also might be an underestimate of methamphetamine-associated deaths, because not all death certificates necessarily test for the drugs that are involved in an overdose or necessarily list them. And then something else that's important to point out is that we're talking about acute overdose mortality. So these are deaths where the drug poisoning contributed to the death. As we mentioned previously, methamphetamine is incredibly toxic and it does damage organ systems over time. There's sometimes methamphetamine use associated HIV. So our methamphetamine death data aren't going to reflect those more long-term causes of death. So then on the next slide, here are our take-home messages. So as you can see by the data presented by Beth, the numbers of adults aged 18 to 64 with methamphetamine use and use disorder have increased. There's also among the population of people who have entered treatment facilities for methamphetamine use, that population has reported an increase of use of injection as a usual way of using methamphetamine. So that's a higher risk way of using methamphetamine. And there's been an increase in age-adjusted death rates of methamphetamine-involved overdose, both alone and in combination with fentanyl for most subgroups, and that has continued through the COVID-19 pandemic. So as we described earlier, that methamphetamine use disorder and injection are higher risk than methamphetamine use without either of those. So those categories, the prevalence surpassed methamphetamine use without those behaviors in each year from 2017 to 2019. We found that adults with methamphetamine use disorder or injection also tend to use methamphetamine frequently, which is again one of those higher risk categories. During 2015 to 2019, the adjusted prevalence of meth use disorder without injection more than tripled among women, more than doubled among men, increased over tenfold among Black people, tripled among white people, and more than doubled among Hispanic people. So correlates of methamphetamine use disorder, frequent use, and injection include lower educational attainment, lower income, not having insurance, experiencing housing instability, being involved with the criminal justice system, and having comorbidities, suicidal ideation, and polysubstance use. Sort of the larger story here is that populations that are at increased risk for methamphetamine use disorder have diversified really rapidly. So this means that more people are exposed to risk for methamphetamine use disorder, and overdose deaths is just one example of that. As we discussed, there are many other risks associated with methamphetamine use disorder as well. And actually, since you guys are going to be talking to Sam Quinones, I will mention him here because I think one of the hypotheses he's derived from speaking to people who use methamphetamine is the idea that the P2P precursor might be associated with more severe outcomes. So this is something we get asked about a lot. So far, the experts at NIDA don't necessarily think it's a precursor issue because P2P-derived methamphetamine has been around for a very long time. But it's certainly possible that there's greater toxicity potentially in the drug supply. The people that we speak to tend to think that it is actually the different patterns of methamphetamine use that might be driving the more severe psychiatric symptoms that people are seeing. So I think it's kind of like, at this point, a pedantic pharmacology question that should probably be separated from the very real concerns that people are seeing on the front lines of more severe psychiatric symptoms of methamphetamine use. So the next slide has additional take-home messages. So as mentioned, the way that we're seeing the patterns of methamphetamine use are changing in a way that is riskier for overdose and other adverse outcomes. So it's really important that we do what we can to combat the surge in methamphetamine use disorder and implement effective prevention and treatment interventions. Right now, an unfortunate reality is that we don't have any FDA-approved medications for the treatment of methamphetamine use disorder, and contingency management is the most effective behavioral treatment, but uptake of that continues to be limited. So medication development for psychostimulant use disorders in general, and specifically methamphetamine, are a huge research focus area for NIDA. So we are looking at a lot of potential medication candidates. We're also looking at interesting approaches such as vaccines, monoclonal antibodies, and sequestrant molecules that bind methamphetamine and keep it in the bloodstream, and then it's evacuated and never reaches the brain. So these are kind of novel things that are in the works that we hope will someday give us an FDA-approved medication or antibody to treat methamphetamine use disorder. And they can also essentially be useful for treating methamphetamine overdose if they're able to keep the methamphetamine from reaching the brain. So another really important tool that we need to scale up are harm reduction interventions to prevent infection transmission associated with injection drug use. So syringe services program could absolutely help mitigate overdose risks. NIDA funds a lot of research on harm reduction as well. And by the end of the month, we're going to be funding a large new initiative about novel harm reduction approaches. And then also, given the fact that sometimes people whose drug of choice is methamphetamine take methamphetamine that has been contaminated with fentanyl without their knowledge, it's possible that access to drug checking technologies could be helpful for people to be able to identify if there's fentanyl in their methamphetamine. So fentanyl test strips are one example that are now purchasable with government grant money that could be helpful in that way. All right, next slide, please. So this is just an example that we were excited about, but our particular little corner of NIDA is the science policy branch. So we identify scientific questions that are policy relevant, and then we do these analyses as Beth has presented, and then we pair with our communications colleagues to do press pushes and try to get the story broad coverage. So there was a ton of press coverage around these two stories, and then legislators picked it up, and the Office of National Drug Control Policy now has a meth strategy that obviously these papers didn't create, but they definitely brought greater attention to it. So yeah, that is our mission, and we are very pleased to be able to share it with you today. Thank you so much, and we're happy to discuss whatever people would like to talk about.
So I did have that actually written down on my sheet of paper about the P2P meth. I'm glad you referenced that, so we didn't have to go there. But Carly, do you want to just ask that question?
Sure. I'll first just start by saying that about the prior point that I commented about, I just think it's really important for clinicians when talking to patients to not couch questions in terms of sexual orientation, and to always, because many people identify as straight, yet under the influence of methamphetamines, have all sorts of sexual behaviors that they would not identify in terms of their sexual identity, and yet it is an important risk factor. So just to be cautious in how you ask patients about their sexual behavior, which is an important conversation. So the classic teaching on meth, this is my question, the classic teaching on meth was that it had a specific geographic distribution. It was more common on the West Coast, the sort of Rocky Mountain states, and into the sort of rural Midwest. So Hawaii, San Diego, Portland, these would be methamphetamine hotbeds, whereas some of the more East Coast cities and regions would be less. And then also in the Midwest, more rural, less urban, things like this. And I wonder whether the demographic changes really represent geographic changes, and to not over-interpret the changing demographics as like something's happening in the African-American community. And it's less about that, and it's more about meth is now available in areas where African Americans are more likely to live. Did you get my point? Can you comment on the geographic changes versus demographic changes, and which is leading and which is following those trends?
Yeah, go ahead, Beth. You can start.
That's a really great question, Charlie. These are the national trends. And I use the public use file, which the SAMHSA try to reduce data disclosure risk. So they don't include the state and region in the public use file. So I was not able to look at, for particular region or particular state and any trend between 2015 or 2019. So all I will present actually at the national level, because NISDA provide nationally represented data. Yeah, but I believe you have raised a very important question.
So I'll just give you one example, and then I can stop talking. If you took the rates of methamphetamine use of Asian and Pacific Islanders in Hawaii, and compared it to the rates of methamphetamine use of Asian and Pacific Islanders in Cleveland, Ohio, you're going to see dramatically different rates, at least in 2019. I don't know about today, because Hawaii is geographically such a heavy methamphetamine using area that it may not be their race. It's the fact that they're living in Hawaii. And the same demographic living in a different geographic city may have different rates. I would be curious about that. That's the classic teaching. But of course, now methamphetamines is sort of everywhere. So I don't know if it matters as much.
Yeah, that's why even at national level, we find out that, diversity really, you can see intensified so rapidly. Yeah. Emily, go ahead.
Sure. Yeah, I was just going to reiterate that that's not really a question that we can ask with this particular data set, but it's a fantastic point. And we've definitely seen an increase in meth infusion into Appalachia and also into the Northeast where it wasn't previously. And I think it's a great point that so many outcomes are so driven by the drug supply. For example, our precipitous increase in overdose deaths, fentanyl is everywhere. And that aspect of the drug supply is the reason we're seeing what we're seeing. And so much of addiction and overdose risk in general is more related to, the external environment and social determinants of health. But I think one take home from the fact that these are changing among all races and ethnicities, certainly related to the supply, but it underscores the fact that if a provider once thought methamphetamine is not a problem in my community, that's maybe no longer the case. So it's important to address it.
Yeah, I think that's interesting. And along that same line is you had such good response rate. Actually, I thought those response rates were pretty good when you sent out whatever. And, were there gaps in the response rate in terms of certain areas of the country responded more than others? Or, were there any gaps? And you said, Beth, that you didn't have necessarily that fine-grained data at your hands when you put all the data together, but it would be interesting to see if there were some of those trends if you looked at the nitty-gritty data points to kind of speak to that.
Thank you. Actually, had another important question regarding survey response rate. The reason I used 2015 through 2019, I didn't mention 2020. You know why? Because during the COVID, the response rate was so low. When we talk about response rate like 75%, 67%, and during the COVID, it was around 6.6%. So somehow, I'm not sure how I can use the data. So that's why we use the 15 to 19 data. But I totally agree with you. Survey response rate, who we collected, who we missed, that tell another important question.
Yeah, and kind of to Charlie's point, I think if this was a self-report survey too, how people are going to respond to all different questions, whether it's race, whether it's sexual orientation and all of that versus, sitting with a patient in clinic, sometimes it takes a few visits for a patient to disclose some of the behaviors for different reasons too. And so I appreciate that Charlie pointed that out just for the people who are sitting with the patients, just because of a lot of the high risk in the complications, if you will.
There's a little bit different actually during the NISTA data collection. The interviewer not necessarily know what the respondent answer because we use the audio computer assistant, self-administered interview technology. So it's a very confidential way for respondent to record their answers. So a little bit then, when you sit in the clinical setting and right in front of many other patients or in front of other, health professionals. Yeah.
I found it interesting that when you looked at some of your levels of injection, how those stayed the same despite the numbers of meth use going up 3 and 4 times. Is there anybody that's kind of explained that? Why are we seeing the number of people that are actually injecting kind of staying the same despite the total increase?
Actually, I have 2 different slides. One is at the population level that when we use the national surveys on drug and use and health. So that's the population level. And the other actually is using the test data. We basically is admission to substance treatment facilities. So you can see at the treatment level, you can see methamphetamine injection, you can see the admission going up with whoever report actually injection as the usual route of methamphetamine use.
I think that's a good point about sort of some of the limitations of the NSDA. It's fantastic because it is a nationally representative data source, but when you get to some of these riskier outcomes, they might just not be as well captured by that. So as we mentioned, people who are experiencing homelessness and are not in a shelter are a population that could very well have large amounts of injection use, and incarcerated populations. And I think the increase that we see in people seeking treatment is really salient because that kind of, it narrows it down. We know these people use methamphetamine and are seeking care for it. So seeing an increase there, I think, is potentially more reflective of what's actually happening.
And I think some of these questions, and do you guys work with an analyzing group? Because I mean, this is data put as data. And do you work and sit down at NIDA with people to kind of understand why these trends are existing? Like the question that just came up, any trends in asthma or inhaling deaths with methamphetamine just because of the route of use?
Yeah, that's a great question. So my understanding of our mortality data is that it would be categorized as methamphetamine involved and not necessarily tell us if there was bronchospasm associated with that. Is that true, Beth? Yeah, so we would need to have a smaller, more targeted study that looks at sort of qualitative aspects of overdose death situations. But I think the SOAR's data might get at some of these things. Is that correct, Beth, at CDC? So it wouldn't be a national mortality data set, but it would be a subset of states that do more in-depth interviewing around overdose deaths. But I would kind of doubt that this is one of the outcomes that they're assessing.
Yeah, we had a SOAR.
I highlight the multi-cause of death data. Basically in the death record, death certificate, they usually have maybe like 10 options. So they have primary, the leading death, secondary, and third. So what we find actually from these, based on ICD-10 code, we got these any overdose death are involving methamphetamine. But I didn't examine, whether also include an asthma or other related chronic conditions. However, as Dr. Einstein, present in the earlier slide, showing that distribution of the methamphetamine in the body once a person uses it, and you can see it has dramatic damage on the brain, on the heart, on the lung, kidney, liver, basically all the major organs you can see.
Right. Yeah, we had a presentation on SOAR's data for Minnesota that MDH had done a couple of months ago, maybe now. And, I think some of these questions were coming up there too, and it is hard. It's one of those studies you wish you could interview every patient from every single possible aspect. And so I think, just seeing this data, understanding, like you had said at the end, Emily, that there are limitations, that's huge, because even with how it is now in the data with limitations, it is just obviously a gross underestimation too. So.
Asthma associated cause of death is a good one in which even if they are published. So obviously the go-to for reversing an opioid overdose is naloxone because it's working right there in the same receptor. But then there's been increasing reports of the sort of wooden chest syndrome, chest wall rigidity associated with fentanyl. So it's really important for our basic scientists to know what mechanism should they be looking at here? Because if it's an adrenergic mechanism causing that, then naloxone's not going to do anything. So having a better understanding of exactly where the mortality is coming from is important. So most of the methamphetamine overdose reversal projects that we're working on are focused on just keeping the methamphetamine out of the brain. But if it's a pulmonary cause of death, that's not going to do the trick. So yeah, it's really important for us to to hear from the field what's going on.
And I think it is harder with that. And then we had a question privately said about attributing, attributing cause of death, like an opioid overdose, like if that's what it is, it's obvious in more aspects, meth overdose, because usually it's not just meth that caused the death. And so is it really just that, or is it's the complications of the meth that caused the death and meth just got ignored in a way?
Yeah, so if you only look at overdose death, basically we are going to, severely underestimate the methamphetamine related mortality. So you can see most people died from stroke, myocardial infarction, and pulmonary hypertension, hepatitis B and C, HIV/AIDS. So, and you can see even people get psychosis, depression, all other mental disorders. So it's quite different from opioid overdose. Opioid, addiction and methamphetamine addiction. You will have very dramatic damage on many key organs. So that's we highlight in the earlier slides.
All right.
Any other questions?
All right. Well, I think we are out of questions for the day. We really so much appreciate you guys coming on today. I love the information. I think it's helpful for everybody to kind of get the big picture. So
yeah, I think
thanks for having us.
Another interesting study here, do more work, would be just specifically going in and surveying, jails and prisons. And, if you could separate out just that population, then it would be very interesting. And obviously these wouldn't be overdose deaths, but it would be just getting those use trends and just seeing what that looks like compared to the population you were able to gather.
Yeah, keep an eye out. There's a lot in store there. So SAMHSA has underway a project to kind of address the population that's missed by the NSDA. And then we have a really large research initiative called the Justice Communities Opioid Innovation Network. They do assess other substances as well, but there's been such a dearth of specific data for this population. I remember recently, like 2009 was the latest you could actually find that was nationally representative. So keep an eye out for JCOIN findings, because they're going to start to have a lot more information about carceral populations.
Wow, that will be very interesting. Well, thanks again for your time. We really appreciate it, our friends from NIDA. So maybe sometime down the road, we'll revisit some of this and when some new data comes out. So thanks again.
Thanks so much.
For having us.